I'm Kohei Shitara. I'm a GM medical oncologist in Japan. In this spotlight and growth study, we investigated the efficacy of zolbetuximab as a Claudin 18.2 targeted monoclonal antibody for gastric cancers. So as you may know, we have still limited treatment options for patients with gastric and GJ cancers. We can use kind of conventional cytotoxic chemotherapy, but the efficacy is not enough. We can also use HER2 targeted therapy like trastuzumab or recent trastuzumab deruxtecan, but it can be applied for very limited fraction of patients, like 10 to 15% of population. And recently, chemotherapy plus checkpoint inhibitor is approved in many countries and can be used as a standard of care in frontline. But the benefit of checkpoint inhibitor is also mainly enriched in patients with specific characteristics like high PD-L1 and MSI high microsatellite in stable population. So clearly we need additional new treatment. So that's why this Claudin 18.2 targeted therapy is developed. And Claudin 18.2 is usually tight junction to connect the normal cell and the normal cells. And during malignant transformation to gastric cancer, this protein is exposed on tumor cell surface and it becomes good target. And importantly, around 30 to 40% patient maintain high level of Claudin expression. So this is a good target. So this is two studies compare the chemotherapy, first-line chemotherapy like FOLFOX and KFOX in combination with zolbetuximab compared with chemotherapy alone. And it already shows an improvement of progression-free survival. This means the time until disease progression or death, as well as overall survival in previous analysis in each studies. In this combined analysis, we combined these two studies and updated overall survival result. So these two studies is both global phase 3 study, but there is some difference. One is a backbone chemotherapy. A spotlight study applied FOLFOX as an infusional-based chemotherapy, and a growth study applied KFOX, which is oral administered agent in combination with oxaliplatin. And there is some difference of country distribution. GROW is a more China-driven trial, and some different countries enroll patients in each trial. So there is a difference. So that's why we combine these two studies. These combined analysis clearly suggested an improvement of progression-free survival and overall survival. Actually, median progression-free survival was 9.2 months with zolbetuximab and 8.2 months with chemotherapy alone, and the hazard ratio was 0.71. That means around 30% risk of disease progression or death at the time point. And importantly, median overall survival was also improved by around 3 months with a hazard ratio of 0.77. So considering the limited treatment option in gastric cancer field, this is a quite good news for us and our patient to have an additional treatment option. And it showed it maintains the quality of life in general. There's no significant difference of change of quality of life during the treatment. Because of the toxicity related to zolbetuximab, which include GI, gastrointestinal toxicity like nausea, vomiting, and anorexia, especially occurred at the early phase during treatment. So quality of life score is a little bit decreased if we focus on nausea and vomiting scoring, but in general, overall scoring is very consistent between two arms. So maybe I need to talk a little bit about the toxicity. Again, there's an increased incidence of nausea and vomiting with zolbetuximab. Usually these toxicity mainly occurred during first infusion. especially occurred maybe 30 minutes to 1 hour after beginning of infusion. A patient may feel some uncomfortable epigastric abnormality or nausea, and some patients experience vomiting. So there's some important toxicity management plan or mitigation plan, including antiemetics use and change of infusional speed. So there is such kind of data to support such toxicity management is helpful to reduce such toxicity. So as a result, these toxicity and efficacy balance support the use of this chemotherapy and zolbetuximab treatment for our patient. And as you may know, this combination is already approved in Japan and also in UK and the EMA very recently. This study clearly supports the use of this combination for biomarker-selected population with Claudin 18.2 positive patient. So to test Claudin is very important for patient to evaluate the indication of this treatment. And then, as mentioned before, there's a unique toxicity with this agent, which occurred during administration. So this is very important for patient and the nurse, because nurse is usually most important staff during the administration of this agent. And again, it is recommended to use multiple antiemetics like NK1 inhibitor, 5-HT3, and corticosteroid, and in some patients olanzapine. These are somehow helpful to reduce the toxicity with this agent, as well as chemotherapy-induced nausea. And there is also guidance to recommend a slower infusion at the beginning. And if patient are feeling good, we can also increase or speed up the infusion rate. And usually, in my experience, it needs 3.5 hours or close to 4 hours at the first administration. So first administration is very important. But if patient complete the first administration, next administration, usually patient doing better, feeling better. So such nausea and vomiting less frequently occurred at the subsequent cycle. So to know the common toxicity like GI toxicity, and to know the management plan, including use of antiemetics and change of infusion rate with a slower infusion at the beginning, followed by faster infusion after feasibility, confirmation of feasibility of a patient. So this kind of information should be very important for your nurse. Usually, a patient have some, usually may afraid about this kind of toxicity, but as a doctors, I usually explain the benefit of this agent, as well as the expected toxicities. And again, it is very important to explain this kind of toxicity should be decreased at subsequent cycle. So if patient have some symptom at the first administration, this may not be true at subsequent cycle. So to continue this kind of treatment for long period is very important for gastric cancer patient to maintain the disease control and the quality of life. So never give up for each treatment by toxicity should be very important. So as a result, I always respect the work by nurse and support, as well as a pharmacist to explain the such toxicity and prepare toxicity management. So such kind of multidisciplinary team approach for each patient must be very important.